Okay, well, welcome to the first webinar, IBC GT Metabolic. This is on magnetic surgery, the use of linear magnets, but this is a more advanced program. We have presented before on magnetic duodenal ileostomy after sleeve gastrectomy and for type 2 diabetes, but this is, and as well on gastric magnets for MAGI, magnetic gastroileostomy, for the same reasons. But this, we have assembled experts, as you've seen in the video. We have, I have to make an announcement that Dr. Helmut Billy, because of an emergency, could not join us as a moderator, and Dr. Ajay Upadhyay,
Upadhyay, yes.
Upadhyay, I'm sorry,
Yes, you got
it's
it.
my French. My French is very difficult to read this in French, and is a bariatric and robotic surgeon at Alta Bates Summit Medical Center in Oakland, California. He's replacing Dr. Helmut Billy, and at the last 24 hour, he has accepted to help us, and he's actually a robotic expert using the linear magnet. So he's also the medical director of metabolic and bariatric surgery and past chair of the robotic steering committee at Alta Bates. And our second moderator is Nestor de la Cruz Munoz. He's director of metabolic and bariatric surgery, HCA Florida Healthcare, Miami, Florida, and the medical director of metabolic and bariatric surgery at the Mercy Hospital, Miami, Florida. So thank you very much. Dr. De la Cruz, you can announce the first speaker if your microphone is open.
Right. Thank you, Dr. Gagner, for the opportunity of being here. And it's my pleasure to introduce Dr. Michel Gagner, who's going to be our first speaker. He's internationally recognized as a pioneer in minimally invasive and bariatric surgery. He was originally trained in Canada at Université Laval. My French is not very. And he completed advanced surgical training and quickly became a global leader in laparoscopic techniques during the early evolution of minimally invasive surgery. He is widely credited as being one of the first surgeons to perform a laparoscopic adrenalectomy and has been a major innovator in complex abdominal procedures, helping to push the boundaries of what could be accomplished through minimally invasive approaches. Through his career, he's held prominent academic and clinical positions at leading institutions, including McGill, the University of Pittsburgh, Mount Sinai Medical Center in New York, and institutions in Florida. He's deeply involved in education, mentoring, and advancing surgical science with hundreds of peer-reviewed publications, textbook contributions, and international publications. His work has significantly influenced global adoption of early laparoscopic and robotic techniques, particularly in bariatrics and metabolic surgery. Dr. Gagner is especially well known for his contributions to bariatric surgery, including early adoption and refinement of procedures such as the biliopancreatic diversion with duodenal switch. And he's been a strong advocate for innovation, outcomes-driven surgery through evolution of techniques to improvement of care. Today, he's going to be discussing magnetic compression surgery and the distalization of the Roux-en-Y gastric bypass. Thank you, Dr. Gagner.
Thank you. Thank you. Can you see my screen?
Yes.
Someone
Yes,
will
we
have
can
to
see
say
you.
yes, because
Yes.
I don't know. Okay. So my talk is magnetic jejunal ileostomy for revision of Roux-en-Y gastric bypass. As you know, the meta-analysis in the Annals of Surgery just recently published has looked at the systematic review of the efficacy of limb distalization for inadequate weight loss after Roux-en-Y gastric bypass. There are different types, and I'm not going to go to all the types, but I think the two that are most common is type 1, in which we disconnect the alimentary limb at the Y and move it distally. So the tall is the measurements of from the gastric pouch to the ileocecal valve. And the 2B, I think, is probably also the second most common one, is moving the biliopancreatic limb from the Y, disconnecting it, and doing an end to side more distally. That's the 2B. Now, usually the type 1 with alimentary limb is often at 350 centimeter, is associated with less risk of malnutrition. And if you do about 350, you can expect a percentage of excess weight loss of 51% with 70% resolution of type 2 diabetes and 60% of hypertension. And it may vary with age. Another significant review from obesity surgery in 2023 is from Gislason as a senior author, and they've looked at, again, the type 1 in which you transect the alimentary limb from the Y and move it distally. And they've looked at two tall, 250 and 300, so a bit less than what the Annals of Surgery has reported. And they have a long-term follow-up. The percentage of excess weight loss reaches 62% at 3 years with a 250 centimeter. If it's the tall is 300 centimeter, then the percentage of excess weight loss decreases by 10%, but there's less potential nutritional complications. I want to review with you shortly this side-to-side magnetic jejunal ileal bipartition, because before we started distalization, we learned some experience by doing a side-to-side jejunal ileal bypass. And this was done in Prague with Professor Martin Fried, who's a previous president of IFSO. And you can see that from the 100 centimeter from Trites and 150 centimeter from the ileocecal valve, a side-to-side magnet was positioned and the mesenteric defect was closed. He was doing this with staplers for several years, and it's an accepted procedure covered by the medical health of Czech Republic. So we went in his operating room and we did a series of cases in which the patient swallowed the first 5 centimeter and 2 hours later swallowed the second 5 centimeter. Here's an X-ray showing the 2 magnets, and when they joined together almost 4 hours later, and we went in the operating room and undocked the position, because obviously it is anywhere on the small bowel, often in the proximal small bowel with the more distal small bowel, and able to surf these magnets at the proper measurements, and then close the mesenteric, redock them and close the mesenteric defect. No enterotomies. So individual patient lost, this was done for type 2 diabetes, and they lost modest amount of weight, as you can see, but really great reduction of hemoglobin A1C and glucose. And in fact, when the patients had continuous monitoring of their glucose, when the anastomosis was happening, when the 2 magnets went through the small bowel, there was an immediate drop of glycemia. That's before they were passing their magnets by defecation. So we decided to do something similar, and this is to do a type 2B distalization. We would have the patient swallow the first magnet. This would be brought in the common channel. The second magnet would be after the patient is asleep with a gastroscope, bringing it to the alimentary limb. And here's the first swallow. And then this second magnet would be brought by laparoscopic positioner through the Y into the biliopancreatic limb with a clamped temporary bulldog so that we don't have complete distension of the small bowel while this is taking place. After the endoscope is removed and the magnet is surfing the biliopancreatic limb, the lower magnet was surfed to the 150. They would be docking together, and then the mesenteric defect would be closed. Of course, after several weeks, the magnet pair is passing. So let me show you the first video. This patient will get a distalization due to weight regain after she had a good gastric bypass, Roux-en-Y. And as you can see here, there was 61-pound weight regain. And the patient swallowed the magnet 5 centimeter. You can see the X-ray attest that the magnet is below the iliac crest. We are measuring the limbs here. This is a umbilical tape of 25 centimeter, and I decided to measure the alimentary, the biliopancreatic limb, and the common channel. Now, this alimentary was 75 centimeter, and the biliopancreatic limb was about 50 centimeter, and the common channel was actually 600 centimeter. So here we're measuring the limbs. Because I did not do this bypass, and you never know what the reports are saying exactly. There could be mistakes in the measurements. This is the 150 centimeter from the ileocecal valve. I put 2 metal clips on each side of the mesentery, and then I continue approximately to measure this common channel. Now, the swallowed magnet was found in the alimentary limb. I use a laparoscopic positioner. This is an 18 Newton, and the patient has somewhat little contraction of the bowel. We use here in Canada Buscopan, which is hyoscine. And you can see here I'm passing next to the Y on the alimentary limb because there's continuous mesentery, and I'm going distally. I will continue to surf this quite far. And here I applied a bulldog clamp to insert the second magnet with a gastroscope attached to a catheter. And I catch it again with the same laparoscopic positioner. The catheter is released from the magnet, and then the endoscope is suctioning the bowel. I will then remove the bulldog clamp since the endoscope is now gone to prevent complete distension of the intestine from insufflation. We use CO2, which helps. And then we're surfing this from the alimentary limb to the biliopancreatic limb. So here we are, the contraction is done with bowel forceps that are flat fenestrated. And you can see here, there shouldn't be too much force as we approach the, here's the junction, the Y. And here, interestingly, there's a blind limb to the Y, the biliopancreatic limb. So we don't want to go there. We want to go the opposite direction in the biliopancreatic limb. And I just pull, and now I'm in the biliopancreatic limb. And I will continue a distance, mid-distance, about 25 centimeter or so. Now, I go on the common channel, and I'm looking for my other magnet, and interestingly, the magnet I left in the common channel has already docked with the biliopancreatic limb. But obviously, this is not distal enough on the common channel, so I will surf. It is possible to surf the pair. And here's a demonstration. I pull the common channel, the proximal common channel, and bringing the distal common channel in with the biliopancreatic limb. And here I arrive at the clips. And I will then close the mesenteric defect transversely. I use a Silk 2.0 non-absorbable, and I will close this in a running fashion. I often incorporate a little bit of the serosa of the intestine because you don't want, as they lose weight, this mesentery, fat mesentery can disappear, and you can have a small opening between the bowel itself and the mesentery. Here we arrive towards the end. It's important to take good bites. You see, I didn't take a good one. Now I'm grasping the mesentery of the common channel and the mesentery of the biliopancreatic limb at the end of this transverse closure, and we are tying it, and that basically constitutes the distalization of 2B, type 2B of this patient. Here's the post-op immediate X-ray and the clips you see above, the lateral view, and this patient passed the magnets more than 2 weeks later. And here's the post-op at 3 weeks that shows that the magnets have passed and the clips are present. So there's a second type 1 that can be performed. This is alimentary limb to common channel, and the patient would swallow the first magnet. We will surf this to 150. The second magnet is introduced by endoscopy at 100 centimeter from the gastric pouch, and then we put them side by side and close the mesenteric defect, and several weeks later it will pass by defecation. So this distalization permits hypoabsorption of calories and fat, but it's a bipartition. It's not the same as what the annals of surgery and the other one show, because it's an end to side. Here it's a side to side, so we expect less mineral and vitamin deficiency because there is the normal flow into the other side. There's no enterotomies. Mesenteric defect must be closed to avoid internal hernia. It has the potential of an outpatient procedure, and it is reversible because you have one shot of the stapler and it will reverse everything into an easy way. Just to remind you that we have our symposium in Montreal, June 26, 27, with 6 live surgeries and more than 30 talks on various subjects, including colon surgery with the magnets and gastric magnets, very interesting, and biliary magnets. So thank you very much.
Thank you very much, Dr. Gagner. I wanted to start by asking a question that I see you presented both ways, type 1 and type 2 distalizations. And is there one that is preferred or any difference in data in terms of outcomes?
I think biliopancreatic limb to common channel is complicated because the mesentery is tricky. If you are using the alimentary limb and you go along the common channel, I think that this is a continuous one mesentery, and I think it's less tricky to do with the magnet side to side. So I would advocate that probably the type 1 is an easier performance. The tricky side is the mesenteric defect. You know, if you have twist and you don't identify the defect correctly, you're going to end up with a bowel obstruction of some kind in the post-op period.
Okay, Dr. Upadhyay, do you have
Yes.
a question?
Yeah, Dr.
Any
Gagner, does the common channel, we have found the same thing, common channel in some of these bypass patients who have gained weight is 600 centimeter and some is only 200 centimeter. Does that help you figure out what to do and also?
I don't know what to do. I don't have enough experience in, surgeons have anecdotal experience. I remember when I was at Mount Sinai, New York, and this was almost 30 years ago, I started to do distalization by laparoscopy with staplers, and I ended up end to side too dramatic, and I ended up with reversing some patients because of hypovolemia, hyperproteinemia. It is my hope that the side to side will diminish that risk. It's probably not zero, but what to do in someone who has short total element, limbs, I don't know. I think if we still do 150, 100, it will be a total of 250, let's say, out of 350, 400. I think the risk will be relatively small for that patient. The risk is bigger on patients who have 800, 900, and you're doing 250. So
Right.
perhaps on those patients, you may want to go to 350.
Thank you. Yes.
It's empirical.
Yes. Yeah.
Okay. Thank you very much. I think we have to move on with the program. Dr. De La Cruz Munoz will introduce the second speaker. Oh, maybe he's gone. Your microphone.
Yeah, sorry about that. I was a little bit confused. So our second speaker is Dr. Peter Nong. He's the chairman of the Department of Surgery at UNC Rex Physicians. He's a Raleigh native, and Dr. Nong is a nationally recognized expert in bariatric and minimally invasive surgery. He completed his medical training and surgical residency at East Carolina University at the Brody School of Medicine, and has spent more than a decade advancing complex bariatric procedures in the community-based setting. Dr. Nong is particularly well known for his expertise in duodenal switch and SADS, where he not only performs these procedures at a high level, but also publishes, presents, and teaches on their application around the country. He's a diplomat of the American Board of Surgery, a fellow of the American College of Surgeons, and a fellow of the American Society for Bariatric and Metabolic and Bariatric Surgery. Today, he'll be sharing his experience and insights on leveraging linear magnet compression in patients that benefit from elongation following a previous DS surgery. Dr. Nong.
Thanks. And we'll start with the video, and then I'll be happy to answer questions relative to that. Magnetic elongation after duodenal switch. The patient presented today is a 52-year-old female with malabsorption syndrome after prior laparoscopic BPDDS in 2019. She experienced successful weight loss, losing over 90 pounds. However, she experienced progressive challenges with protein levels, fat-soluble vitamin deficiency, and intermittent diarrhea. Her albumin had drifted to 1.8, and with nutritional support recovered to an albumin of 3.2. This slide illustrates our typical trocar positions using a 12 mm left upper quadrant trocar for the laparoscopic positioning device. The camera is placed in the periumbilical trocar, and the right upper quadrant trocar is used for the assistant arm. We start with identifying the terminal ileum and measuring the small bowel in a retrograde direction. We follow the alimentary limb first, including the common channel at 120 centimeters, to the roux limb. We use 10 centimeter marks on the grasper to gauge length with modest stretch. We then reach the ilioileostomy, noting the position of each functional limb, common channel, biliopancreatic limb, and roux limb, then proceed proximally on the roux limb at 200 centimeters length. We identify the distal 100 centimeters of roux limb for our future magnetic anastomosis, marking this with ink. We follow the remaining roux limb proximally to the level of the duodenal ileostomy. Next, we redirect our attention to measuring the BP limb. We return to the ilioileostomy and find the BP portion, following this down to approximately 100 centimeters. Again, we use this point, marking it with ink, with plans to create our anastomosis. We then measure the remaining biliopancreatic limb for total length and identify the ligament of Treitz. We return to the BP mark and place a tacking suture to the omentum. This creates a docking point for the distal magnet. Next, we place a bow clamp on the proximal roux limb to avoid insufflation of the small bowel during magnet delivery. The magnet is delivered endoscopically using the magnet delivery system. First, we dose the patient with 2 milligrams of glucagon and deliver 20 milliliters of mineral oil endoscopically. This facilitates delivery and magnet surfing. The magnet is passed using a combination of scope manipulation and casting the delivery wire, cannulating the sleeve and then the duodenal bulb. You can see here how the upper sleeve can often trap the magnet, and by pulling the scope back, advancing the wire, and allowing the curve of the wire to turn through the sleeve, you can cannulate the upper sleeve through the incisura and into the antrum. Next, we will manipulate the wire to access the duodenum and position the magnet into the duodenal bulb. Once captured by the LPD laparoscopically, we can release the applier. Surfing the magnet requires patience and gentle handling of the intestines. Small bowel injury is one of the real risks of this procedure. Positioning the LPD in a forward position allows the magnet to advance with a pulling motion. Ideally, the surgeon keeps the magnet orientation along the antimesenteric border, while the assistant holds the serosa to avoid mesenteric or serosal injury. We typically use a three-hand technique to straighten the path and stretch the bowel, which allows for a smoother forward delivery of the magnet. Here we cross the ileostomy, and you can see we can use the LPD to redirect the transition through the ileostomy into the BP limb. We run the magnet all the way to our docking suture and then detach the LPD, leaving the magnet in the biliopancreatic limb. We reclamp the proximal Roux limb and deliver our second magnet. You can see here the endoscope delivering the magnet into the duodenal bulb. We use the LPD to capture the magnet, and once the magnetic delivery device is detached, we can reposition the LPD in a forward position and advance the magnet to the Roux limb mark. We next identify the BP magnet and use the grasper to position this over the ink mark. We then point this in the direction of our proximal magnet and allow the two to marry. We can do micro adjustments, bringing the magnets into the proper position along the antimesenteric border. We routinely apply a crotch suture both for fixation of the bowel and removal of any undue tension, and to assist with closure of the mesenteric defect. We feel it's important to avoid internal hernia and bowel obstruction via closure of the small bowel defect. You can see here we use a running Surgidac suture. This technique is closed from the bottom up using a horizontal mattress technique, and you can get very nice alignment of the mesentery. Finally, we remove our docking suture as we want to avoid inadvertent adhesions or small bowel obstruction. Finally, we obtain a post-op image as well as a 1 and 2 week image to confirm clearance of the magnet. So it's a fairly straightforward technique. It's really an adaptation of the kissing or Braun technique that we do for our standard stapled technique, adopted really from Morceau and the group in Quebec and their large experience with limb lengthening. So we found it to be extremely effective. And what's really nice is we're able to send people home the same day in most cases. I think the strategy has really allowed us to have more flexibility around offering a less invasive approach for limb lengthening. So we're very excited to see this option. I'm happy to answer any questions.
This is Ajay Upadhyay. Dr. Nang, thank you for that video. What difference have you seen between doing with the standard stapling technique versus the magnets now, since this is a bipartition, their weight gain and other things? Is there any difference? Have you seen?
I think the outcomes have been very similar. I mean, I think the most interesting experience around it has been it's really done as an outpatient, which is obviously not typical when you're doing an anastomotic procedure. But also, it's very gentle, if you will. There's less overall pain and discomfort. The body takes around 2 weeks on average to mature the fistula. And when that happens, you see a very dramatic improvement from the patients in terms of the resolution of GI side effects. Their energy levels improve. Their ability to absorb is clearly there. And we've tracked so far, we've seen very, very low issues around any readmissions, ED visits, and related complications. Because, I know that we all do anastomoses all the time. And, I think the reality of it is that they are inherently procedures that have risk, whether that's a leak or bleeding. And even though that's relatively small, it's nice to have a tool that you can offer really effective outcomes and with low morbidity. So we're excited to offer it.
Thank you.
Thank you. I had a comment. I don't have as much experience as you, Peter. I called you because I had one patient, and actually the only difference that I did was that the first magnet I had the patient swallow. I was kind of worried that this magnet would end up in the colon, so I took an X-ray not 2 hours but 1 hour later, and actually the magnet was in the above the Y, so it permitted me to avoid one endoscopy. And surfed that one. I picked it up right away and went to the biliopancreatic limb, and then I did one endoscopy after that to position the one as you've demonstrated. So that's
there's actually
variant.
I think it's a great variant. I think that in our world, as you and I have spoken about this, the swallowing the magnet in pre-op in a community setting is, from just a timing standpoint, a little bit more of a challenge. But I think and we've actually messed around with using an overtube, and so that you have an easy access. You're not really performing 2 endoscopies per se. Your overtube's in place, and that allows you to drop the magnet at will. And it's a very elegant way to kind of solve the problem.
Yeah, Peter, a nice presentation there. I enjoyed it. And one of the things that before I did my first revision case with these was I was worried I would have a difficult time passing the magnet through an anastomosis. And I'm wondering, now that you've done a bunch of these, has that ever been an issue, or does it usually slide through easy?
I think they generally slide through very easily. I think the limiting factor is more my experience around surfing, and you've done this. I mean, there's a little bit of a learning curve with handling the LPD and redirecting it, but once you kind of get how to twist that hinge towards the anti-mesenteric border, it really you learn to drive it, and it's become a very simple technique. We like that three-hand technique. You can see it really gives you just a straight shot, and it's very efficient. And in this case, you saw we're handling a lot of bowel. We're measuring the bowel. We're running the magnet down twice, and so very careful handling of the intestines is incredibly important.
Very cool. Thank you very much, Peter. We will continue the program. We've done the revision of either shortening or elongating the bowel limbs. Now we're going to go into reversal. So the first paper is entitled Laparoscopic Reversal of MagDI, or Magnetic Duodenal Ostomy. And Dr. Lamis Al-Mutlaq, who is a bariatric and minimally invasive surgeon at the Westmount Square Surgical Center in Westmount, Quebec, Canada, will be presenting the technique. She has done her residency and her fellowship at McGill University in bariatric surgery. So Dr. Al-Mutlaq, please.
Hello, everyone, and thank you to our host for the invitation and the opportunity to present. I'll be showing a video of a laparoscopic reversal of magnetic duodenal osteomy. So let's start with our case. Our patient is a 55-year-old female. She started off with a BMI of 41 and had undergone a laparoscopic sleeve gastrectomy in 2021. She had very good weight loss results in the first couple of years. However, 3 years later, presented with some weight regain. She was struggling a lot despite following with a multidisciplinary team. She did not tolerate any of the GLP-1 medications, and her BMI started to climb back up and reached 33. She also developed dyslipidemia. And at that point, we felt that it was appropriate to offer her a bipartition procedure as a second step, as this is less aggressive than a full SADI. And so she underwent a laparoscopic magnetic duodenal osteomy, which was uneventful. She did develop symptomatic biliary colic at about 3 months later. Essentially, she was having some pain, some nausea and vomiting. And an ultrasound was done that showed some evidence of gallstones. And we proceeded with a laparoscopic cholecystectomy with intraoperative cholangiogram. But she continued to have symptoms nonetheless after, especially the nausea and vomiting were persistent, but then started to develop also hypokalemia, hypoproteinemia, hypoalbuminemia, and it was very difficult for her to keep up with her minimum daily requirement of protein and hydration. So at that stage, especially that her BMI was dropping significantly, the decision was made to reverse her original surgery. So just to show you the original surgery, this is what it looked like with 2 magnets, one in the duodenum and one in the ileum, which created our bipartition magnetic duodenal osteomy. And so our case begins with placement of 4 trocars along the umbilicus. And we start by exposing the closure of the mesenteric defect. This is to eliminate the presence of an internal hernia, and you can actually see the intact closure and the silk suture that was used to close Peterson's defect between the mesentery of the transverse colon and the mesentery of the ileum. We then shift our attention to run the small bowel, starting at the ligament of Treitz. We are looking for any causes of partial obstruction. We continue to run the biliopancreatic limb distally until we reach our anastomosis. And so here you can start seeing the anastomosis defined by this fine white line at a distance of about 2 centimeters from the pylorus. there's minimal adhesions around the anastomosis. And so we decide to proceed with our plan of reversal. In order to do that, we simply lift up the duodenum, and we pass a 60 millimeter linear stapler. We anticipated that because we had used a 5 centimeter magnet to create the original anastomosis, that a 60 centimeter will be sufficient. And this is done in a single firing. Now, it's very important at this stage to make sure that we are really in the middle of the anastomosis to avoid any narrowing on either side of the duodenum or ileolumens. And because this patient had presented with hypoproteinemia, hypoalbuminemia, and essentially malnutrition, we go ahead and oversew the staple line. This is done with a 3/0 monofilament absorbable suture. In this case, we are using a length of 25 centimeter, and we're making sure that we are staying close to the staple line as to not cause any narrowing. This will help prevent any leaks, but also prevent any bleeding as well. It is done on both sides of the staple lines in a running fashion. And this is replicated on the ileal side as well. And once we are done with that, we start running the small bowel distally from the staple line towards the ileocecal valve this time. Again, we are ensuring that there is no other cause that might be contributing to the patient's symptoms, such as adhesions or bands. But it also confirms the initial distance of our common channel, which we had planned at 250 centimeter, but this is just a confirmation to make sure that this common channel was not shorter for whatever reason. And so the patient did super well. She was discharged on postoperative day 1. And when she presented for her follow-up appointment at roughly about 3 months post-op, she no longer had any symptoms of nausea and vomiting. She actually had a little bit of weight regain, and she had normal electrolyte and nutritional parameters. Now, as you can see, a reversal of a magnetic duodenal ileostomy is not that difficult. And although this is not done very commonly, it is reserved for patients with severe malnutrition, for instance. It is straightforward as a procedure. Thank you very much for this opportunity, and I'll be more than happy to take questions.
Ajay Upadhyay is simple but elegant, I think, really. The weight gain you said is about 5 kilogram over a period of few months?
Oh, that was for that specific patient that we had, but they do essentially regain, I would say, between 5 to 10 pounds or 5 kilos, if you may, on average, especially in the beginning after their symptoms resolve. We have only done a handful of these.
Very, very nice. Will you consider GLP-1 in these patients if they gain more weight?
I mean,
Or
the issue
anybody else?
with these patients is that, they had intolerance to the medications, which was why it led us to do the MagDI in the beginning. But if this was a planned from the get-go sleeve plus, for instance, and we had to reverse and there was weight regain, I would consider that for sure.
Lamisa, beautiful video. Was there any consideration of, if you will, calibrating the magnetic anastomosis instead of reversing it? The idea that maybe, as we know that the weight effect, if you will, is size dependent, and could you have reduced the anastomosis in half with suture and maybe achieved both the success of less side effects, but maintaining long-term effects?
Yeah, that's actually a very good question. And I know that in one case where it was a reversal of a gastrocnemiectomy, we had considered essentially using an endoscopic approach to minimize the size of the stoma. We eventually, because of the malnutrition, severe malnutrition, we really wanted to make sure that we reversed that more than anything else. Again, it's in over 700 cases worldwide. Like I said, it's only been a handful, so we're still in the beginning trying to figure out. But in these cases that we have done, they were really severe malnutrition, and patients were quite symptomatic. So we wanted to reverse them as much as possible. As fast as possible, just to get their parameters back up. But it is definitely a consideration that we have thought about, especially thinking in the beginning of managing their symptoms before they get to a point of maybe severe malnutrition.
We we are approaching 800 cases of magnetic anastomosis, and the reversal is 1.4%, something like that. So it's not that frequent, and it's a little bit like the series of Quebec City when you see, the problems of full duodenal switch and patient gets into trouble. You go over them and you give them nutritional support. Some may need total parenteral nutrition. You give them a chance, and if they're unable to cope with the protein or the symptoms, it's like the patient who are unable to tolerate GLP-1. I'm wondering if you do this anastomosis and the GLP-1 goes way to the roof, and then they have the symptoms that are similar to their intolerance. So the other problem, Peter, is that in order to put a stitch with these endo stitch thing, endoluminal one, you need some space, and the duodenum is very small, as opposed to the stomach, where you could do some sort of a TOR stitch procedure. It may be more expensive than doing a stapling reversal. There's also the cost that could play into the decision.
Yeah, I think it's a fascinating approach, and I think that, I think there's a lot to learn, because we're realizing that even in the elongation world, you don't have to elongate or reverse everything. It just 50 to 75 centimeters dramatically changes a patient's clinical outcomes. So that's exciting. Nice job.
Thank you. I think Dr. Cruz will. Thank you very much, Dr. Mutlak. Well done. The last paper, Dr. Cruz Munoz will introduce the last speaker.
Yep. Thank you. Thank you. Dr. James A. Foote is a board-certified bariatric surgeon and fellow of the American College of Surgeons, recognized for his expertise in both primary and revisional bariatric surgery. He earned his medical degree from Wayne State University School of Medicine in Detroit, and completed his general surgery residency in surgical critical care through Grand Rapids Medical Education Partners in affiliation with Michigan State University. His training provided a strong foundation in complex surgical care, critical care, and advanced operative techniques. He currently serves as assistant professor of surgery at Michigan State University and practices at Corewell Health in Grand Rapids, Michigan. His clinical practice is a blend of primary bariatric surgery and advanced revisional procedures, where he focuses on optimizing outcomes for patients with complex surgical histories. He's been at the forefront of minimally invasive surgery with extensive experience in laparoscopic, robotic, and endoscopic approaches. In addition to his clinical work, Dr. Foote is a respected leader in the field, having served as past president of the Michigan Bariatric Society. He's committed to advancing bariatric and metabolic surgery through education, innovation, and collaboration, and remains actively engaged in teaching and sharing best practices to improve patient care and surgical outcomes. Today, he'll be discussing his experience utilizing linear magnets in the reversal of Roux-en-Y gastric bypass, sharing practical insights and real-world application of this evolving technique. Dr. Foote.
Oh, thank you so much. Yeah, I was had some experience, of course, reversing gastric bypass like we all have, and found that, a lot of times they would either gain all their way back, or they would get severe reflux, or some of the things that you perform the gastric bypass for. So I searched for another solution where we could restore flow back to the duodenum. And so I'll share my video here and then answer questions at the end. Let's
see.
This is James Foote. I'm presenting reversal of gastric bypass using magnetic compression and anastomosis.
Excuse me, doctor, we don't see your screen.
Yeah, let me get you there. Let's see, I gotta move this. There we go. This is James Foote. I'm presenting reversal of gastric bypass using magnetic compression and anastomosis. As far as background, gastric bypass can lead to the complications of hypoglycemia, marginal ulcers, malnutrition, vitamin deficiencies, uncontrollable diarrhea, and frequent stools. Gastric bypass can be reversed with a gastrogastrotomy, and this is the most common type of reversal of gastric bypass. The Henle-Longmire loop has been described, which uses an esophageal jejunal anastomosis and a gastro-jejunal anastomosis to restore normal anatomy. The Broncho-Zorn switch has been described, which uses a jejunal interposition, resection of the remnant stomach, and resection of residual roux limb in order to restore normal anatomy. This is an example of the Henle-Longmire intestinal loop, where the roux limb is essentially reanastomosed back to the remnant stomach. This is an example of the Broncho-Zorn switch. This is where the roux limb is essentially connected to the duodenal stump. I had performed a similar operation for reversal of gastric bypass for a patient with hypoglycemia. In this case, the patient had a previous sleeve gastrectomy with a stricture and were unable to use the sleeve gastrectomy. In this case, where I did a sutured reversal of the roux limb to the duodenum, she was a 37-year-old female. Again, she'd had a gastric bypass performed. That was a conversion of a sleeve gastrectomy. She's had a cholecystectomy, hiatal hernia repair, hysterectomy in the past. Her initial BMI for her gastric bypass was 45. She got down to a BMI of 33. Her reflux resolved, but she had daily hypoglycemia into the 30s, resulting in desire for reversal of the gastric bypass. As I didn't think there was enough room to perform a gastrogastrotomy, and the fact that the patient had a stricture of her sleeve, we did not want to reverse her back to a sleeve gastrectomy. We decided to resect the remnant stomach just beyond the pylorus, performing a resection or a division of the roux limb about 40 centimeters from the gastrojejunostomy. I chose 40 centimeters so we did not have any reflux of duodenal contents back into the pouch, and then performed a hand-sewn anastomosis between the roux limb and the duodenal stump. Postoperatively, the patient did well and her hypoglycemia resolved. In our first case, using the magnets, this was a 27-year-old female. She had a BMI of 58.17 at the time of her gastric bypass. Her gastric bypass was performed in 2025. She had 150 centimeter roux limb, but she suffered from severe diarrhea and dehydration. She was constantly in the infusion centers and complaining of frequent loose stools. On 10/13/25, we performed a laparoscopic reversal of the gastric bypass with duodenal jejunal magnetic compression anastomosis. And here's her video for procedure. We had to free up some adhesions around the duodenum. You can see this is the remnant stomach. We're able to create a gastrotomy on the posterior wall of the remnant stomach. There's the pyloric valve. In this case, we used a 5 centimeter magnet still attached to the retrieval device. And we simply position this into the remnant stomach. I actually sutured the gastrotomy partially closed to avoid any gastric spillage during the manipulation of the magnet. This was further closed at the end of the case after we removed the wire. We then used the positioning device to direct the magnet beyond the pylorus and into the first and second portion of the duodenum. The second magnet was placed endoscopically down through the esophagus, down through the pouch and into the roux limb. And again, we used approximately 40 centimeters of the roux limb to create the new anastomosis. Here we're using the positioning device on the second magnet to bring the magnet up to the duodenum and make the attachment. The two magnets are now connected just past the pylorus. We're able to do some manipulation of the magnet in the bowel to be assured it was beyond the pylorus. And you can see there's the roux limb now with the anastomotic connection to the duodenum. And you can see it's right down to the duodenum. This patient did well postoperatively. She's had several follow-ups in our office and her diarrhea has resolved and she continues to lose weight. She's actually lost approximately 83 pounds total since her original gastric bypass last year. The second case is a 58-year-old female who underwent a laparoscopic sleeve gastrectomy in 2016. She then unfortunately had a motor vehicle accident where she had to have small bowel resection. She had a head injury. She was not good with her nutrition postoperatively. She had severe reflux. We eventually had to convert her to a Roux-en-Y gastric bypass on 2/19 of 2025. Unfortunately, her body mass index dropped and she had malnutrition. The patient could not maintain her weight. On 2/23/26, the patient underwent a laparoscopic reversal of the gastric bypass with duodenal jejunal magnetic compression anastomosis. In this case, this patient had massive amount of adhesions. This is actually the remnant stomach stuck to the anterior abdominal wall from a previous feeding tube. We're able to get that down, made a gastrotomy, and what was left of the sleeve gastrectomy remnant stomach. We now position a 5-centimeter magnet down past the pylorus again, keeping it attached to the delivery system to make sure we could retrieve the magnet if we had to. And you can see it does go pretty easily beyond the pylorus into the duodenum with some manipulation here. The second magnet was placed approximately 40 centimeters down the roux limb using an endoscope. We used the positioning device to take the magnet in the roux limb and approximate it to the magnet which was in the duodenum here. Making that connection just beyond the pylorus. The remnant stomach was stapled off and this piece was removed. This patient is just about a month out from her procedure. She has passed her magnets, but we're still waiting to see what the results are for her malnutrition.
Very cool.
Yeah, I actually have a third case coming up next week, similar reversal. So
That's cool. That's cool. I've done one reversal for this patient. I did a gastrostomy. I had to put an opening in the remnant, drop a magnet in the fundus attached to a catheter, and the second one coming down in the gastric pouch, connect them close. I actually put a gastrostomy in the remnant because this patient was malnourished. This patient had a Roux-en-Y gastric bypass and ended up with internal hernia in another hospital and had a bunch of small bowel resections, actually 4 anastomosis. And there was a total of 200 centimeter. So I wanted to use the duodenum umbilical pancreatic limb pathway, and she's regained weight after the connection, and I was able with the gastroscope to demonstrate the two anastomosis. She's got the pathway going into the roux, and she's got a pathway going into the remnant. And that seems to be sufficient for her maintenance of daily nutrition at the moment. We'll follow her. But that's your Henley foot Henley magnetic procedure, and or Zoron foot procedure. I don't know how to call it. Do you have a name?
Not yet. I'll try to think of something.
It's very elegant. I like it. As we have this in our armamentarium, and the reversal are difficult. The revisions are difficult. There's a lot of scar tissue in some cases, and these patients have a higher rate of complications. So if we can bring it down by using the magnets, I think it's a plus.
I'm interested to see, because it's a bipartition too, perhaps they're not going to gain all their way back like a total reversal will. I think it's going to be very interesting. Yeah.
Yeah, Dr. Foot, I've done about 6 reversals, and the last one was more than 10 years ago, when we were doing a lot of gastric bypasses for different regions. What was this patient, why did you choose just 40 and not 60 centimeter for the reflux? Were they okay? Were there any recurrence of reflux in any of these patients?
Yeah,
no?
So the one patient that's a little further out, I asked her specifically about that, and she complains of no reflux, after the procedure. I did want it short enough that we could still access it, endoscopically too.
Right,
so I thought 40 centimeters would be reasonable.
Okay.
That's cool.
Very good, yeah.
Okay. Any Dr. Nestor, any question? Dr. Peter, any question?
No, I didn't have a question. I just wanted to say it was wonderful to see that magnetic anastomosis in the duodenal sweep and a revision that's going to be a difficult and high risk anastomosis be really simplified and decrease the risk. So I think this is a big push forward.
Yeah, I had the same comment, which is, these revisional operations are technical challenges, and it's amazing when the most difficult part of the operation is the exposure, and the anastomosis is now arguably a bit of an afterthought. And that's a great advance. And to have the confidence that you can have the kinds of micro adjustments and the ability to adapt your tool to almost any anastomotic space is going to be a great advantage for us in the future. Nice job.
Yeah, thanks. That's kind of why I showed the surgical one too. That was a bear compared to the magnetic one. So
yeah. Well, I congratulate all of you. Thank you very much for this nice demonstration. I think, when in just a few years we've seen the one type of anastomosis now to revision, reversal, and different permutation. I think we'll hear more about it in the near future. It's interesting. Thank you very much for your participation. Thank you, Dr. Ajay, for coming the last minute and replacing Dr. Helmut. Thank you for your comments and moderations. And I don't know if Prof. Rogula is here to close the webinar.
We would like to thank the faculty for taking part in the webinar today, and would like to share this sponsored promotional video.
The biggest issue in bariatric surgery is how invasive is the operation? What are the risks of the operation? We only operate on 1% of the available potential patient population within bariatrics. And so much of that is built around the fear of an operation.
We do ridiculously complex operations and make them seem easy. As we get into harder and harder things, we're going to need more and more assistance.
And anything that we can do to make the operation simpler, safer, less traumatic is going to be a huge win for bariatrics and for patients.
We've been dealing with a platform of sutures and staples for 20, 30 years, and to have a new paradigm is something that is just amazing. And I'm sure that there are going to be a lot of surgeons that once we have data, they're going to be amazed with what we're going to be able to show them.
When we talk about doing enterotomies or making an anastomosis and we're sewing it, there's always that risk of leak and technical failure. And so far, it doesn't sound like we're seeing anything like that. Being able to swallow a magnet and drop another one down and put the two together, I think a patient's going to see that as something that's a lot less invasive.
Being able to shift that into an outpatient venue allows it to be expanded, first of all, from a cost standpoint and a care standpoint to a larger population of patients, and in turn, be able to allow us to offer these procedures to more patients.
I think this is definitely the future. Our goal is zero complications, so I think this is kind of taking us to that next level.
This is a groundbreaking technology in surgery, and I think that what avenues this opens up for surgeons is just amazing.